Good evening, everyone. Welcome. Good evening, colleagues and delegates, and thank you for registering for this first of the two rheumatology webinars which we have planned as a part of the Ambalal Modi Conclave 2020, which has for the first time gone virtual because of the pandemic. My co-chair for this webinar is Dr. Bankim Desai, and we will go through the actual webinar after a few minutes once we see a small clip from Cadila Industries, followed by a welcome message from the President, Mr. O.P. Singh. Over to you, sir.
एक ऐसा समय जिसने हर किसी की जिंदगी को एक नया मोड़ दिया। एक डॉक्टर से लेकर एक स्कूल जाते बच्चे तक सबने अपने रोजाना जीवन में कितने बदलाव लाए, लेकिन सबने दूर रहकर भी एक दूसरे को आगे बढ़ने में मदद की। ये उन वॉरियर्स की, उन आइकन्स की बात है जो दिन रात दुनिया को इस कठिन परिस्थिति में भी आगे बढ़ने का रास्ता दिखा रहे हैं। ऐसे ही एक आइकन थे श्री इंद्रवदन अंबालाल मोदी, भारत में मेडिकल क्षेत्र में अपने अविरत योगदान के लिए जिन्होंने एक नई राह की ओर पथ प्रदर्शन किया।
उम्मीदों की भरकर गठरी युवक एक निकला था घर से, बस सच्चाई और मेहनत की ताकत उस गठरी में भर के। ये ठानी थी उसने मन में कि राह अलग सी चुननी है, विज्ञान ज्ञान को जोड़े जो एक ऐसी माला बुननी है।
ये सीख आपसे पाई तब के इसी राह पर चलना तुम, नई सोच और उल्लास का नारा हर एक दिशा में भरना तुम।
फिर सींचा हमने एक सपना और उत्सव का आरंभ किया, बदलाव की वाणी बोले जो उस पहल का तब प्रारंभ किया। जहाँ दुनिया भर के सबसे उम्दा ज्ञान का होता हो जमघट, जो स्वस्थ विश्व के सपने की पहचान सा लगता हो हरदम। जहाँ नए नए संशोधन को सम्मान मान हर छोर मिले, विज्ञान की अनुपम खोजों पर संवाद जहाँ हर ओर चले। हर शहर पे छाया है अब इस उत्सव का एक रंग, तो चलो सभी जुड़ जाएं, अब आया है माइकॉन के संग। निर्माण की ऊर्जा सदा बहे, आगाज हमें ये करना है, ना कोई बेइलाज रहे, इस लक्ष्य को हासिल करना है।
इस सोच के अविरत उत्सव को अब और शुरू में करना है, देश के कोने कोने तक अपना परचम अब धरना है।
इस लहर का थामे दामन अब हर एक से वादा करना है, खुशहाल जिंदगी के पथ पर एक साथ हमें अब चलना है।
देश का हर जन चाहे ये रंग जाए इस रंग,
अब देश का हर जन चाहे कि रंग जाए इस रंग, और चलो सभी जुड़ जाए, अब आया है माइकॉन के संग। आया माइकॉन के संग।
उम्मीदों को मिलेगा एक नया मुकाम, क्षितिज पर होगा एक नए सूर्य का उत्थान, एक नई ऊर्जा का होगा सृजन, दुनिया भर के ज्ञानियों का होगा समागम। आई एम आइकॉन 2020।
Greetings to everyone present here today. On behalf of Cadila Pharmaceuticals Ltd, it gives me immense pride to welcome all the experts from the respective field to the 8th edition of Indravadan Ambalal Modi Innovation Conclave, which is also known as iamicon. iamicon is more than a conclave. It is a celebration of innovation and excellence in life sciences. Started in 2013 in 33 cities, this conclave successfully reached to more than 151 cities across India in 2019, making it India's largest knowledge conclave. We are also proud to announce that this year, iamicon has broken all physical barriers and has gone virtual. Today, it is India's largest virtual knowledge conclave. At Cadila Pharmaceuticals Ltd, we pride ourselves on being a research-driven organization. For 6 decades, we have been innovating affordable cures in the most challenging healthcare domains. This pursuit for innovation was sown into our culture by our founder chairman, Shri Indravadan Ambalal Modi, who aspired to make healthcare the most affordable through innovative miracles. This vision has been carried forward and sustained in our research endeavors. Our first in the world medical innovation like Polycap, Rezorin, Reviloc IV, Mycidex C, Threvis, 3-dose rabies vaccine, and now Cefsivac, Mycobacterium W, a promising innovation in the fight against COVID-19, are a proof of his vision. As the human race evolves, so does innovation. Each generation provides a new challenge and opportunity for the field of medicine that fuel the innovation of the future. The young, budding doctors present here today are the ones who will lead the march of science into the future. They will be the ones who will be benefited the most by today's interaction on the upcoming medical innovations. On this occasion, I'd also like to take a moment to thank all the COVID warriors working around the clock and putting their lives at risk. This pandemic has made us realize the importance of science and innovation. With this, I would once again like to welcome you all to iamicon 2020, a conclave of innovation. I am confident of a grand success of India's largest scientific conclave with everyone's contribution and support. Thank you so much for your presence. Now, I would like to thank Dr. Namisha Patel, the current president of Rheumatology Association of Gujarat, being a part of this virtual iamicon 2020. I would also like to thank all the eminent speakers and panelists present today, who will be introduced soon by Dr. Manisha Patel. Over to you, Madam Dr. Manisha Patel, to take.
Thank you, Mr. Kapoor. And we are really grateful and happy that we are sharing this journey with you. We had the pleasure of meeting Mr. Modi when he invited us to see his facility. He was a man of words, few words, but his word was as good as any written document today, which is honored. We're pleased to be here. We have a very interesting scientific session ahead of us. I'm going to introduce my co-chair and the panelists before we and the main speaker before we go ahead with the most important talk of this session. Can I have the first slide, please? Dr. Bankim Desai is my co-chair for this webinar. He is the immediate past president of Rheumatology Association of Gujarat and my senior colleague. He has been a very active member of the Association of Physicians of Gujarat and Surat, and has been past president of both. He was the chairman of the iamicon 2012, which we organized in Ahmedabad. and his areas of special interest are rheumatoid arthritis and fibromyalgia. Welcome, Bankim Bhai. Next slide, please. Our main speaker today and guest of honor is Dr. Kaushik Chowdhury. He is a consultant rheumatologist at University Hospital Coventry in the United Kingdom, and he is the present secretary of the British Society for Rheumatology and counselor for the Royal College of Physicians, London. His many feathers to his cap. He graduated in India, did his MD medicine from Kolkata, and after training stints in various institutes, AIMS in New Delhi, Sydney, and UK. He has been a consultant in UK since 2001. He has served as a regional chair of the British Society for Rheumatology and chair of its Education and Training Committee. He is one of the founders of the Indo-UK Rheumatology Forum, which was a very innovative and nice concept, and which has continued till date. This was formed in 2005. He was the chair of the Rheumatology Specialist Examination Committee of the Royal College of Physicians. He is deeply interested in the evolution of treatments of rheumatic diseases. He is a very good speaker, and we would look forward to hearing what he has to say in his talk, Looking Forward in Wonder, a Century of Brilliance and Serendipity in the Treatment of Rheumatoid Arthritis. Next slide, please. We have three eminent panelists for today. None of them require any introduction to the rheumatology community in India and a lot of friends abroad as well. Dr. Balakrishnan is the consultant rheumatologist at PD Hinduja National Hospital, Mumbai, where he trained. He has more than 80 publications in the field of rheumatology in national and international journals and is currently a teacher for DNB rheumatology. His special interests include lupus nephritis, infections in rheumatology, and soft tissue pains. Welcome, Dr. Balakrishnan. Our next speaker and panelist is Dr. Banwari Sharma, clinical immunologist and rheumatologist practicing in Jaipur. His areas of interest include early inflammatory arthritis, myositis, and use of rituximab in autoimmune disease. Welcome, Dr. Banwari. And our third panelist is Dr. Sapan Pandya, our colleague in Rheumatology Association, Gujarat. Until recently an active member of the executive committee, he moved away from the EC to become secretary of the Indian Rheumatology Association. He practices in Ahmedabad and is the assistant professor, Department of Rheumatology and Medicine at the Srimati NHL Medical College and SVP Hospital, Ahmedabad. His areas of special interest include primary Sjogren's syndrome and palindromic rheumatism. Welcome, Dr. Sapan. Dr. Bankim Bhai will say a few words before we start the talk by Dr. Kaushik Chowdhury.
Oh, good evening, friends. Welcome to this webinar. Today's topic is looking in wonder in treatment of rheumatoid arthritis, a century of serendipity and brilliance. In my 3 decades of clinical practice in rheumatology, starting from 1991, there are very few drugs available, starting from those sulfasalazine and the levomazole, and then I used injection myocricin, oral golds, and then the next decade moves into a wonder drug of methotrexate. Of course, the anti-inflammatory drugs and glucocorticoids was there. And then another decade, we have biologics available. Then the biosimilar available. Now we have a small molecule available. So I started wondering myself how it has evolved into such a big armamentarium in treating of the rheumatoid arthritis, and I never thought how it has come about. And I'm so glad that this particular topic has come about, and look back that the thousands of rheumatoid arthritis patients have been benefited with this innovation. So we must look back and see how it has evolved. and none other than our Professor Chaudhary, I would say our Kaushik or KC, is here to deliver this talk on a century-old uh, serendipity of the treatment of rheumatoid arthritis. I invite and welcome Dr. Kaushik Chaudhary to deliver this talk. Thank you.
Good evening and a very warm welcome to all of you for the first rheumatology offering of iamicon 2020. I am grateful to Cadila and to my colleagues at the Rheumatology Association of Gujarat for their kind invitation to speak to you this evening. Today, I shall take a slightly different approach from the conventional webinars that have dominated our educational space for the last few months. Instead of a very technical talk on rheumatoid arthritis, I shall try and take you on a journey that traces the origins of the condition and some of the events, particularly over the past 100 years, that have shaped our understanding to try and get a glimpse behind the scenes and acquaint ourselves with the brilliant men and women who have contributed to the advancement of our understanding of this complex condition, ultimately for the benefit of our patients. So I have titled my talk, Looking Back in Wonder, a century of brilliance and serendipity in the treatment of rheumatoid arthritis. These are my disclosures. Why look back? Carl Sagan, who was an astronomer and a visionary thinker, once said, "You have to know the past to understand the present." I think this would be applicable particularly to those of you who have entered the specialty in the last decade and a half, well after the biologics revolution was underway. It will help us to get a better perspective of our current limitations and to be able to map our future direction of travel by understanding where we began, and how far we have come on that journey. It really has been an incredible ride so far of success, of failures, of jubilation and heartbreak. In Indian classical music, it is customary to pay homage to one's teacher or guru before a performance. I will also pay my respects to my teacher, Professor Anand Malviya, who introduced me to this wonderful specialty 30 odd years ago and also kindled an interest in the history of medicine by his anecdotes. There is a more important reason for mentioning him tonight, and this relates to the term serendipity in the title of this talk. In a 2016 article in which he looked at the discovery of methotrexate and its use in rheumatology, he touched upon the word serendipity. The definition of serendipity is an aptitude for making desirable discoveries by accident, good fortune, or luck. However, as Professor Malviya said in his article, it also refers to searching for something and stumbling upon a discovery of even greater value. The history of therapeutics in rheumatoid arthritis is littered with such events, from gold salts to sulfasalazine, antimalarials, anti-TNF. It is indeed a very long list. In fact, one of the giants of modern medical science, Louis Pasteur, said, "Fortune favors the prepared mind. Serendipity can lead to creativity only if there is an awareness and intellect to capitalize on the luck." The timeline of my talk starts in prehistory. It is, by necessity and limitations of time, going to be a selective and subjective process, and I hope you will kindly grant me that latitude. Although we shall touch upon some of the key thinkers in this area over the past 2.5 millennia, and also consider their impact on the understanding of this condition, my focus will primarily be in the past 120 years, where individual brilliance and collaborative efforts have paved the way for phenomenal progress in our understanding and management of rheumatoid arthritis. Although some archaeologists have speculated that the arthritis existed in Neanderthal man, human remains from burial grounds in North America and evidence from Egyptian mummies have demonstrated quite conclusively that rheumatoid arthritis is a disease of antiquity, easily going back 5,000 years. We will trace that in a very short time and look at the evidence for arthritis in antiquity. We will look at the thinkers who have shaped our understanding, look at how arthritis emerged in popular culture over the centuries, and how the treatments have evolved. So here are some remains from Egyptian mummies and from North American burial sites. There is the papyrus, which talks about treating gout with the extract of the autumn crocus, which is the plant source for colchicine. And what is clearly understood from these archaeological digs is that not only rheumatoid but other diseases like ankylosing spondylitis and even psoriatic arthritis existed in prehistory. Any talk on the historical aspects of medicine has to mention Hippocrates, widely regarded as the father of medicine. Hippocrates had a lot to say about pretty much everything, but also particularly about arthritic conditions. We know his aphorism about gout, but he was also one of the proponents of the humoral theory of disease. He proposed that an imbalance between the four humors or fluids, black bile, yellow bile, blood, and phlegm, as the basis of all disease, including arthritis. And in turn, these humors were related to the four elements: air, water, fire, and earth. These concepts held sway and dominated medical thinking for many hundreds of years after his death, and still resonates with some physicians to this day. Let us fast forward 1300 years, over a millennium, from ancient Greece to Bukhara in Central Asia, and meet the next dominant figure in medicine at the time. Avicenna, or to give him his full name, Abu Ali al-Husayni ibn Sina, who lived around 1000 AD, was a truly brilliant polymath of the Islamic Golden Age and was very influential in many fields, including medicine. He wrote an authoritative treatise on arthritis that influenced physicians for centuries, not just in the Middle East, but globally. I must admit, the rest of my talk will have a very Eurocentric feel to it. That is not to say there weren't medical developments in India and China during these hundreds of years, but perhaps they will have to be discussed some other time. We go forward another 400 years to the 15th century. We can see that from the 1400s, another form of treatment, not just for arthritis, but for a variety of illnesses, had become very popular. And that was bloodletting, taking blood out of the body, what they felt was poisoned blood, And doctors often used leeches at the time to suck this blood out, and therefore they were also called leeches. In the 16th century, 200 years later, rheumatoid arthritis made its appearance in popular art. This painting by the famous Flemish painter Peter Paul Rubens from around 1600, who himself suffered from rheumatoid arthritis, shows the three Graces, the three daughters of King Zeus of Greek mythology. And we can clearly see in the black and white central panel, in the area marked with the circle, the typical deformities of rheumatoid arthritis in one of their hands. Time and tide wait for no man. We move to the mid 1700s and encounter a brilliant clinician who is regarded as the father of British rheumatology, William Heberden. He laid the foundations of the specialty in the United Kingdom, and over the next couple of 100 years, British scientists and clinicians would play a hugely important role in the development of our understanding and treatment of rheumatic diseases. The term rheumatoid arthritis, however, came 100 years later, introduced into the medical lexicon in 1859 by a London physician, Sir Alfred Garrod, who differentiated it from other forms of arthritis like osteoarthritis and gout. Going back to Heberden, the British Society for Rheumatology was previously known as the Heberden Society, and even to this day, we have the Heberden Round and the Heberden Oration, which forms an integral part of the annual conference of the BSR. Progress in medicine is always very slow, and it is a matter of evolution, very rarely revolution. It is a complex tapestry of clinical wisdom, science, technology, and combined with disruptive thinking from brilliant individuals. We now move into the 19th century, and the pace of change quickens in the latter half of the 1800s. Developments take place across the board, and there is a very rich and productive cross-fertilization between medicine and other disciplines of chemistry and physics. One such event was the synthesis of aspirin, acetyl salicylic acid, which would be the main anti-inflammatory drug for the next 50 years. The beneficial effects of salicylin, or the extract of the bark of the willow tree, was known for centuries and used for a variety of inflammatory conditions like arthritis and also for treatment of fevers, which were common at the time. The active ingredient was isolated and synthesized by this dapper young chemist called Felix Hoffmann in 1897 in the laboratories of that chemical giant Bayer in Germany. The left-hand panel shows the great pathologist Robert Koch, who came up with the microbial theory of infection and the so-called Koch's postulates, and that laid the foundations of modern microbiology. The reason he is important to our story of rheumatoid is that rheumatoid arthritis at the time was widely believed to be a result of infection. And that led to the use of heavy metals like gold, antimony, bismuth, mercury, all these agents which were used in the treatment of other infections at the time, for example, syphilis, way before the first antibiotic, penicillin, was available. So this was a typical example of serendipity where the primary premise was wrong, and yet the result was a treatment that has lasted almost a century in the form of myocrycin or sodium orothiomalate that came onto the market in the late 1920s. So here we have a number of different images. The turn of the century ushered in the modern age of rheumatology. We saw the invention of X-rays by Wilhelm Röntgen, for which he was promptly given the Nobel Prize in Physics in 1901. The upper central panel is an X-ray of the hand of his wife, and the other image to the right is a case report from the early 90s, which slightly humorously suggests that the gold is effective in the treatment of rheumatoid arthritis. If you look carefully at the X-ray, you will see that the ring finger with a couple of gold rings, there are no erosions, whilst the other MCP joints are pretty badly affected with erosive rheumatoid disease. Now let's pay some attention to the lower panel. It shows two people who changed our world, but who also had a connection with rheumatoid arthritis. The young man to the right was born 3 years after the elderly gentleman in the center panel passed away. The elderly man belonged to the world of art and not medicine, and the young man revolutionized surgery in the late 1960s. At some point in the 1860s, a group of young artists decided to paint very simply what they saw, thought, and felt. They weren't interested in painting history or historical figures, mythology, or the lives of great men. And they didn't seek perfection in the visual appearances, but they sought and aspired to capture life in its full color and majesty. This movement was Impressionism, a new way of looking at the world and depicting it in paintings. The painting on this slide is called The Luncheon of the Boating Party, and the painter is none other than Pierre-Auguste Renoir, one of the high priests of this Impressionist movement, together with other stalwarts like Monet, Manet, and Pissarro. The reason I mentioned Renoir was because he was riddled with rheumatoid arthritis, which almost certainly affected the quality of his paintings, although he still produced masterpieces that are amongst the most popular to this day. And I'm sure he would have lived a lot longer had it not been for his rheumatoid. Renoir died in 1920, and 3 years later, in November 1923, this gentleman in the lower bottom right panel was born in South Africa. 44 years later down the line, he would go on to revolutionize surgery by performing the first heart transplant in the world in Cape Town in 1967. He was, of course, Christian Barnard, who again had career-limiting rheumatoid arthritis because there was no truly effective treatments during that time. The other aspect of bringing them up is to show how patients with rheumatoid arthritis triumph over their disability and over their disease. The triumph of the indomitable human spirit over all diversity. It was not all doom and gloom. Developments in the understanding and managing of rheumatoid arthritis came thick and fast, mostly after the end of the Second World War in 1945. Notable amongst them are sulfasalazine, introduced by the doyen of Swedish medicine, Professor Nana Schwartz, who went on to head the Nobel Committee for Physiology and Medicine for many years. Then came hydroxychloroquine, or Plaquenil, a drug that was developed for malaria and then repurposed for rheumatoid arthritis. It has been in the news for all the wrong reasons ever since COVID broke out this year. But hydroxychloroquine has remained one of the key drugs for the treatment of rheumatoid and lupus for the last 70 years. Finally, let me draw your attention to the two most significant drugs that I think ushered in the first revolution in the treatment of rheumatoid arthritis. And they are, of course, corticosteroids, or prednisolone, or prednisone, and methotrexate. They do merit some special consideration as they came quite close to each other and are still with us in our daily practice. Methotrexate has morphed into the so called anchor drug for the treatment of rheumatoid arthritis. Prednisolone is ubiquitous in the world of pharmacotherapy, used by pretty much every specialty. And certainly for rheumatologists, it remains the drug we love to hate. And yet we cannot get away from it. We go back to it whenever we are in a tight spot and we don't quite know how best to proceed forward. It is salutary to remember that one of the key drugs so far proven to limit organ damage in COVID 19 is the steroid dexamethasone. Let me take you back to the 1940s, shortly after the Second World War had ended, to the Mayo Clinic in the quiet town of Rochester in Minnesota, USA. Philip Hench, in the central panel, is a physician, and his colleague Edward Kendall, a pharmacologist, who were experimenting with a compound called compound E, or 17-hydroxy 11-hydrocorticosterone, for over a decade. However, it was only in 1948 that the compound was tried on the first patient, a lady with refractory rheumatoid arthritis. And the story goes that from being bedbound for weeks and weeks, this lady walked out of the gates of Mayo Clinic with a smile on her face, and people thought, perhaps a wee bit prematurely, that the cure for rheumatoid arthritis had been discovered. Steroids were hailed universally, and Hench Kendall and Thaddeus Reichstein from Switzerland were awarded the Nobel Prize in 1950, less than 2 years before they presented their data in a public forum, perhaps one of the fastest turnaround times between discovery and the award of Nobel Prize. The story of methotrexate is even more intriguing, from its birth to its evolution into the star drug that it has become for rheumatologists. Roughly around the same time that Hench and his colleagues were fiddling around with the steroids, a few hundred miles to the east and a bit south of Rochester, in a small town called Pearl River in New York State, home to the laboratories of the Cynamid Corporation, which later became Ledele, there was a scientist by the name of Yella Pragada Subbarao, who had been working for several years and had come over from Harvard in Boston. Subbarao was born in Andhra Pradesh in southern India in 1895 and moved to the United States early on in his career. What can we say of this man who hardly anyone knows today? I quote from Professor Malvia's 2016 paper, which I alluded to earlier. Rarely, extremely rarely, a person comes on the world scene and transforms our lives by making a large number of major discoveries in more than one basic field, and is not only denied a Nobel Prize, but does not get to be known by name to most people, including scientists around the world. Subbarao was ignored by his colleagues, by the Nobel Committee, and by the medical establishment of the day in the West. It's not difficult to guess why. He needs to be remembered and honored, not because of his discovery of the folate antagonist, initially aminopterin and then its methyl derivative methotrexate in 1948. This was achieved with active encouragement from another great man of medicine, Sidney Farber, who is in the central panel talking to this child. He was one of the pioneers of the treatment of cancer and leukemias particularly. A story fabulously told by a New York-based hemato-oncologist, originally from Delhi, Siddhartha Mukherjee, in his 2014 Pulitzer-winning The Emperor of All Maladies, an absolute tour de force and well worth reading. No, Subbarao needs to be remembered because of his role in the synthesis of folic acid and ATP, both key molecules in biology. The use of methotrexate, however, did not enter into rheumatology practice till well into the 1960s, and the first randomized clinical trial showing efficacy of methotrexate in rheumatoid was published as late as 1985. When all this was happening in the United States in the world of pharmacotherapy for rheumatoid arthritis, just over a decade later, in a dedicated orthopedic hospital called Wrightington Hospital in rural Lancashire in England, where the rheumatology department now is headed by my friend Gladstone Chelaya, the first artificial hip joint replacement was being pioneered by Sir George Charnley. And this ushered in a new era of surgically tackling damaged joints, particularly the large joints, the hip and the knee, later on, which were destroyed by the ravages of arthritis, be it rheumatoid or osteoarthritis. The swinging 60s gave rise to the 70s. In the world of medicine, Godfrey Hounsfield builds his first CT scanner. The beginnings of MRI and its transformation into a diagnostic tool in medicine begin to take shape. In the world of arthritis, I'd like to touch on a few other important advances that were taking place during the 70s. First of all, let me introduce you to Sir John Vane, who was originally from Birmingham and later worked in London. He was awarded the Nobel Prize in the early 1980s for elucidating the importance of prostaglandins in mediating inflammation and defining the differences between cyclooxygenase 1 and cyclooxygenase 2 and their role in producing different kinds of prostaglandins, particularly the COX-2 mediated in pro-inflammatory prostaglandins is what we were interested in as rheumatologists. His work formed the basis of what would be the first designer molecules for the treatment of inflammation in the form of COXIBs or COX-2 specific non-steroidal anti-inflammatory drugs. They were launched almost 25, 26 years later in the late 1990s to much fanfare. Rofecoxib and celecoxib quickly became quite popular and held sway for a few years. Their advantage was they had much less gastrointestinal toxicity. It was only a few years later, around 2004, that they came under a cloud because of issues around cardiovascular risk. And rofecoxib had to be withdrawn from the market. No one came out of this fiasco unscathed. The researchers who did not show all their data, the industry sponsors of the trials, the journals that published the data, all round conflicts of interest, and the failure of regulatory agencies like the FDA. I'm not sure that enough lessons have been learnt. The other important elements in the care of rheumatoid arthritis that emerged in the 1960s and 70s was the concept of measuring disease. Intuitively, it made sense. One had to measure if a patient was deteriorating or improving. But unlike diabetes or hypertension, rheumatoid arthritis is a complex disease and it's not easy to measure accurately just by looking at one or two parameters. So from these modest beginnings in the early 60s, our ideas about how to measure this condition optimally has evolved over several decades and has been refined in an iterative process and by international cooperation from the help of bodies like OMERACT. Initially, the emphasis was on measuring X-rays, but there were several such scores, and today we still have the Van der Heide version of the SHARP score. But Dorothy Ritchie, working in Glasgow at the time, who was a physiotherapist at the Royal Infirmary, came up with a clinical index which relied on the patient's tender and swollen joints. There were other indices on both sides of the Atlantic at the time, but eventually the rheumatology community has now settled on what are called composite indices, and looking and different elements relying on patient reported outcomes, laboratory tests like inflammatory markers, ESR, CRP, swollen or tender joints, and the most widely used disease activity score, of course, these days is the DAS 28, or the disease activity score based on 28 joints, which came out of the Netherlands in the 1990s. Other findings that started way back in the 50s but then evolved and more specialties adopted was medical ultrasound. Medical ultrasound was pioneered by an obstetrician, Sir Ian Donald, working at the Women's Hospital in Glasgow. He was intrigued by the use of sonar during his work with the Admiralty during the Second World War, and he helped transform this technology into a whole new diagnostic tool, which, of course, was initially used in obstetrics and later has been established in as one of the key diagnostic tools in radiology, in cardiology, and more recently in the last 20 odd years in rheumatology. Musculoskeletal ultrasound has completely transformed our approach to joint inflammation assessment, as have the other significant change in imaging, development of the MRI. So we have now reached the latter half of the 70s and the early 80s. And although along this journey we have come across many drugs which have helped us treat our patients, some of whom which are still being used on a daily basis, things were not as well as they should be. The use of these drugs was very subjective, a hit and miss affair. The evidence was either non existent or very weak. Despite everything being thrown at our patients during this time, in some of them, the disease progressed inexorably and caused a lot of joint destruction, leading to disability and significant morbidity. This is a slide which shows what rheumatoid arthritis does to an elbow joint. It was lent to me by Professor Ian McInnes, who uh, was well known to the rheumatology community and with whom I shared an office for 3 years in the mid 1990s in Glasgow. This graphically illustrates the relative inefficacy of available treatments. And the rheumatologist is a bit like the statue of Hamlet in Stratford-on-Avon, not far from where I live now, who doesn't quite know which way to turn and is deep in thought, pondering his next step. Some other disturbing facts about the disease surfaced from the work of Theodore Pincus in Nashville and James Fries from California, which showed that not only did poorly controlled rheumatoid affect the joints, people already knew that, but it also had a huge impact on the overall quality of life and how it affected the patient as a whole in terms of activities of daily living, in being able to sustain employment and so on. And some very important tools were developed at the time, one of which is very widely used today, the Health Assessment Questionnaire. So the work of Fries and colleagues showed that although there was a fall and rise in the flares of rheumatoid arthritis like a sawtooth, the overall progression of disease and disability was always in one direction, which was the wrong direction. It was downhill. The other thing to emerge from the mid 1980s was how rheumatoid affected patients, not just with their joints, but in terms of survival. It was with great consternation that rheumatologists woke up to the fact, mainly from the work of Ted Pincus, that active rheumatoid was equivalent to not to 3 vessel coronary disease and stage 2 Hodgkin's lymphoma in terms of morbidity and mortality. This and data from other parts of the world galvanized the rheumatology community into action. It was time to ditch the age old and much beloved pyramidal approach of softly, one drug at a time, starting with non-steroidals for 6 months, which based, the pyramid's base, and then sequentially using other drugs. That simply was not working. So people talked about the inversion of the pyramid, and that was a huge paradigm shift in received wisdom in terms of our approach to rheumatoid arthritis. So, what then emerged was the concept of treating early, treating aggressively, and if necessary, treating with combinations of more than one disease modifying drugs. Now, in theory, that seemed very well and good, but there were problems in recognizing whom to treat early. We did not have the tools to decide who could benefit from relatively low grade treatment and who would need aggressive treatment. Clinical trials became far more sophisticated and ambitious in their scope as we went into the late 80s and 90s. The aversion to combination therapy gradually ebbed away. In this slide, I've highlighted some of the landmark trials that I think fundamentally changed our approach to treating rheumatoid. I'd particularly like to mention the work of James Odell from Omaha in Nebraska, Martin Boers from the Netherlands, John Kerwin, who was professor of rheumatology in Bristol and has done a huge amount of work on corticosteroids and has established that steroids actually are disease modifying drugs. One of my most favorite trials, and I think very underrated trials by the rheumatology community, is the Ticora trial, which started very late in the 1990s, and it was conceived and executed by my former boss, Professor Hilary Capel from Glasgow, and Dr. Duncan Porter. It was first aired in 2003 at the ACR plenary session as the first clinical presentation that year, and it clearly showed that an intensive approach with conventional DMARDs could give comparable results to those with biologics. The only problem was it was very, very labor intensive, but still worth remembering when we are faced with patients who simply cannot afford biologic drugs. So this slide summarizes the timeline and the changes in the philosophy of treatment to rheumatoid arthritis. We had single drug therapy for most of the 1900s. Then the pyramid approach came in. Pyramid was inverted, aggressive therapy, early inversion, combination therapy, and so on. The story of rheumatoid arthritis now takes another major turn and a leap forward. In the late 80s and 90s, there was a revolution in our understanding of these autoimmune inflammatory diseases, not least rheumatoid. This slide gives us an idea of the swirling soup of cells and inflammatory molecules that are present in an inflamed rheumatoid joint. These were being deciphered and catalogued, and the cellular interactions being mapped out. Pro-inflammatory molecules were identified and eventually targeted for intervention. and this could only be achieved because of advances in other areas. What we had by now was a range of drugs of a level of technological complexity far greater than what was hitherto available. This clearly gives us an idea of the differences of molecular weight of a monoclonal antibody and of the prototype anti-inflammatory drug aspirin. The origins of these monoclonal antibody, or so-called biologic agents as they're now called, lay in the 1980s with the development of technology that came out of Nobel Prize winning murine hybridoma technology. This then led to chimeric antibodies, for example, infliximab, and finally humanized monoclonals in the early 2000s. The work of anti-TNF, however, started in the late 80s with the discovery of endotoxin-induced serum factor called cachexin, or tumor necrosis factor. Anti-TNF was initially developed in New York by a small biotech company called Centocor for the treatment of sepsis. It was called CA2 at the time. Unfortunately, CA2 was a spectacular failure in sepsis and threatened to take the company to the brink of bankruptcy. However, again, phenomenal serendipity kicked in. The panel to your right shows Professor Sir Mark Feldman and Professor Sir Ravinder Maini. Feldman and Maini were working at the time at the Charing Cross Hospital in London at the Kennedy Institute. Feldman was a basic scientist and Professor Maini was the professor of rheumatology. They repositioned this drug, anti-TNF drug, for the treatment of inflammatory arthritis, initially in mouse models and later in human volunteers. And the rest, as they say, is history. Their work earned them many honors, including knighthoods and the Lasker Prize, which is regarded as the American version of the Nobel Prize. And once again, serendipity triumphed. They conclusively showed that the effectiveness of anti-tumor necrosis factor monoclonal antibody were quite spectacular. And this opened up a whole new world of biological treatments targeting different parts of the inflammatory cascade. The gentleman to the left of Professors Maini and Mark Feldman is Jonathan Edwards, who is also from London, from a different institute, the UCL. He was the first to reposition and trial rituximab, an anti-B cell monoclonal antibody used for the treatment of lymphoma. And these are the two landmark papers which have virtually revolutionized our treatment of rheumatoid arthritis in the modern age. The first was the ATTRACT trial published in 1999, and the second was the trial with rituximab in 2004. So the biologics revolution was well underway by the early 2000s. More and more drugs were being added to the repertoire, and something that was quite aspirational in the decades gone by became a reality, and that is to aim for remission. The only caveat was that these drugs were very expensive. And that, of course, is now being addressed to some extent by the new biosimilars. Still expensive, but less so. Adalimumab is the biggest blockbuster drug in the history of therapeutics. It has clocked up sales in excess of 40 billion US dollars. So as we go along, our ideas changed, and then we have this concept of treat to target. We are now clearly deciding that just controlling the disease is not enough. We are allocating targets, which is basically low disease activity and ideally remission. The only problem, though, is that it is not often easy to reach that target and maintain it. We can get to low disease activity and even remission, but to maintain it is very difficult. And that is because of the plurality of biological systems and of inflammatory pathways. This slide gives us an idea of the various ramifications of the targets and also the various diseases that have been tackled with these biologic treatments. There is really no single pro-inflammatory cytokine or no single target that allows us to have control over the inflammatory process indefinitely. We shall not have an exhaustive discussion today of the post-biological age of the last 20 years. This just gives you a timeline of how things came on board, starting with whiskey with supper in the 1930s, if you like. And then, of course, all the drugs we have touched upon, and many we haven't. We come to where we are at now and the treatment goals of the 21st century. We've already outlined the concept of treat to target, and that is only possible with early diagnosis and early aggressive treatment and having a tight control over the disease. So we have now reached a stage where we have to pause and reflect on the past 120 odd years. We know a lot more about the natural history of the disease, the epidemiology. We have effective therapeutic agents. We are aspiring towards remission or low disease activity. Clinical trials of newer drugs are now very sophisticated and refined. Patient advocacy groups and patient societies have sprung up all over the world. The use of biologics registries allows us to share our knowledge about these drugs. And biosimilars have made a huge impact on the cost of these drugs and making it more accessible. But there is still a long way to go. We are still working out how best to individualize treatments and how to best pitch it for maximum benefit versus risk. We do have the tools for early diagnosis and effective management, but we do not as yet have the tools of predicting outcome or prevention to the level we would like to. I think prevention is really the holy grail that we should be aspiring to. We will be increasingly thinking of personalized medicine. We have to be cognizant of the central role of the patient in whatever we do. We have to be mindful of the societal cost of these interventions. It is okay to come up with very technologically advanced solutions which are incredibly expensive, but we have to be careful that they're not priced out of the pair. So when it comes to looking and gazing at the crystal ball, I think it is all a question of nomics, if you will pardon the pun. It's genomics, proteomics, metabolomics, more importantly, economics. We started with Hippocrates, and we are almost to the end of our talk, and therefore we have to bring in Hippocrates again. The central tenet of whatever we do in the future has to be around the dictum of primum non nocere. First, do no harm. The dictum has been a particular favorite of mine And this was a mug presented to me by a patient who reminded me I had told her this in our first consultation. Sadly, she passed away a couple of years ago with complex rheumatoid with multiple comorbidities. And I've kept it on my table to remind me that that is what we have to think of all the time. We should not be blinded by technology, but we should use it to our patient's advantage. As they say, with great power comes great responsibility. My last slide, of course, is again one of my favorites, is that of Sir William Osler, widely regarded as the father of modern medicine, or at least modern Western medicine. He was a Canadian, but who retired as the Regius Professor of Medicine from Oxford. Osler is credited with many sayings, but the one I like best is the good physician treats the disease, the great physician treats the patient who has the disease. So, ladies and gentlemen, I thank you for your time. And when it comes to rheumatoid arthritis, or for that matter, any other condition, let us all try and aspire to treat the patient with the disease. Thank you.
Uh, Amazing. Dr. Kaushik Chaudhary, when can I see you? Yeah, Kaushik, this was, I think it's the most difficult lecture to deliver. It seems you have researched, you've done very hard work in trying to put centuries of research that they take hard work by our yesterday's researchers and put it into a nutshell in just 40 minutes. Amazing. I really thank you for that. And you not only touched upon those the people who have found out the how arthritis has developed and have picked up the different conditions. You also touched upon those imaging techniques and the surgical work that people have done for this in those years, and of course, current year medicines that has evolved into today's armamentarium in treating the rheumatoid arthritis. Thank you very much, Dr. Kaushik. We have a few questions lined up or comments lined up for you. And I also want the panelist, eminent panelist, to unmute there. And if they have any comments to make, let me first go to a couple of questions that have come up. And the first one is from Amandep Agrawal. Is there any point in treating asymptomatic or mildly symptomatic rheumatoid arthritis are a positive case reluctant to receive medicine?
Thank you, Banki Bhai, and thank you for your comments. I think rheumatologists have always struggled with the early arthritis or even palindromic rheumatism. It's always a question of being able to read the tea leaves, as they say, in trying to guess which patient will go on to evolve into more sustained inflammatory arthritis, and then also to decide the risk benefit of what treatments to give. It is still, the jury is still out, but I think we are getting better at it. We have now got some markers that will tell us about which patients will go on from being very low grade undifferentiated arthritis to chronic arthritis. So the question is not whether we should treat early arthritis. We of course should. The more difficult question is how do we treat them, and how do we try and gauge who will need more aggressive treatment? And I think that is still to be deciphered.
One more question has come up: is the future of subcutaneous methotrexate versus the oral methotrexate in rheumatology? Will it help to reduce hepatotoxicity?
I am one of the greatest fans of subcutaneous methotrexate. In the past, it was logistically a problem. We had to get it manufactured specifically for named patients in our pharmacy. Now, of course, the whole situation has changed, and I normally in my own practice move on to subcutaneous methotrexate whenever the opportunity exists. It's not possible for some patients for practical reasons. They have deformities and they have no one else to inject them. But I think it is important to recognize that in oral methotrexate, a fraction of what is being given is always absorbed. The whole dose is never actually absorbed, and there has been data to suggest it could vary from anything between 35 to 40% to 70%. On the other hand, with subcutaneous methotrexate, you're practically getting the drug, the dose that is being injected, so you get more bang for your buck. So I am personally a great fan of subcutaneous methotrexate, and I do believe from my own experience that it is better tolerated in most patients.
Yes, thank you. And any other comments from our panelists, Dr. Balakrishnan, Sapan Pandya, or Banwari Sharma, or Dr. Ramisha?
I think it was a very good lecture by Professor. The content was good and the flow was good, as was his English. And apart from the rheumatological content, his interest in the literature was also coming forth, and I really enjoyed the lecture.
Thank you.
Kaushik, that was a wonderful talk. Thank you very much. Are there
Anyone
any other
else?
comments, or we can go on to the first case? Now we will be discussing two cases. Can I have the slide to introduce Dr. Romisha? The two cases which will be discussed by our eminent panelists. Dr. Romi Shah is the budding young rheumatologist who has started practicing in Surat. He has been trained at PD Hinduja National Hospital and Research Center, Mumbai, and has presented research work at national and international conferences. I invite Romi to present his case, and I hand the mic over to the panelists to take the discussion forward. We will give you about 20 to 22 minutes to finish the case and the discussion. Romi?
Yeah, thank you, ma'am. Thank you, ma'am. Thank you, RAG, and thank you, Cadila, for inviting me for this lecture. We'll directly start. I'll share my screen.
Yeah, please.
Yeah. So, is it visible? PPT?
Yeah.
So, we'll directly start with the case. This case I saw when I was at Hinduja with sir. So the history starts with in July 2006 around. He was a 43-year male businessman, a non-smoker, occasional drinker, non-diabetic. Started with history of fever for a month, significant weight loss, deranged LFTs, and hepatosplenomegaly. He was going through extensive workup for that, and the investigation primarily showed high ESR. All the investigations for liver pathologies were negative, like viral markers, autoimmune serology, other investigations were negative. Bone marrow biopsy was done, that was also normal. The CT abdomen was showing splenomegaly with multifocal lesions and mild hepatomegaly with few lymph nodes. So the liver biopsy was done, that was showing necrotizing granulomas with no AFB, no AFB culture. AFB culture was showing no growth. So empirically started on the AKT, but fever persisted. He developed pancytopenia on that. The suspicion of malignancy was high, so underwent splenectomy, and that was also biopsied, and that was showing necrotizing granulomas with again AFB was absent, no TB growth in the culture. So AKT was continued for 9 months and stopped. He had some partial improvement in symptoms with decreased intensity of fever, but fever was there still there. So going further, for in September 2007, he developed inguinal lymphadenopathy. So again, inguinal lymph node biopsy was done. That was also showing necrotizing granulomas. Again, TB was absent from the all investigations, but AKT was restarted, but no improvement, had persistent fever and lymphadenopathy. So again, the diagnosis was reviewed in March 2008. Second lymph node biopsy was done. The histology was same as previous. So thought to as a treated as a MDR TB and started on second line AKT. So in 2008, he developed erythematous papular itchy rash over the right lower limb. So again, skin biopsy that was suggestive of cutaneous TB, but there was like nothing from the investigation was coming out. Then TB growth was negative. AKT was continued and clarithromycin added, but skin lesion persisted. In 2008, he developed right-sided pleural effusion. Pleural fluid was showing high protein, WBC was there, but ADA was normal again and TB culture was normal again. So AKT was again continued and steroid was added. Later tapered to 10 milligram per day. He completed AKT in December 2011, but steroid was continued and had good improvement in that. So again in 2011, his symptoms were persistent. So again evaluated, persistently deranged LFTs were deranged persistently, and persistent skin lesions were there. Again extensive workup for TB negative, second liver biopsy that was showing extensive bridging fibrosis. That was the new development and started to develop cirrhosis also. So prednisolone 10 milligram per day continued, and that was steroid was continued. In 2013, he first time developed lymphedema over the right lower limb and elephantiasis. Skin lesions increased involving back, abdomen, all over the area. That was images I will show you. These were the extensive skin lesions present all over the body. So these were the lesions all over the body, and we can see elephantiasis also. So in 2014, came to us first time. So the overall history was pyrexia of unknown origin, that fever was on and off, hepatosplenomegaly, and the liver second biopsy was showing early cirrhosis also. Lymphadenopathy was there, exudative pleural effusion was once there, and some that extensive skin lesions with no response to AKT, and all biopsies till then date today was showing necrotizing granulomas, but no TB, no evidence, no definite evidence was TB was there. So like the investigation, many investigation were there. Skin biopsy were again reviewed, again Mantoux TB gold done, that was negative, ACE level was normal, and repeat skin biopsy that was reviewed, that was again showing granulomatous inflammation, but no AFB again. So the conclusive diagnosis was there. Then had a discussion with the pathologist. So the possibility of necrotizing sarcoid granulomatosis was considered. And again, steroid was increased 40 milligram per day, and azathioprine was added, but he had no response, like a definite response. Whenever steroids came down to 10 milligram, he had again increased skin lesions was there. So decision to start infliximab was taken after discussion with patient, and had very good response actually. He received 3 injections of infliximab. We can see February, April, and July. So this was the excellent skin response. He had first time, and patient was very happy, and like we were also thinking the disease has responded. This was the before and after image you can see. So he got excellent skin response, but to our agony of that patient, that 2 weeks after third dose, he was admitted in another hospital with fever, seizures, and altered sensorium, with bilateral hearing loss. An MRI brain was showing subdural empyema. Blood culture and CSF culture was positive for that difficult bacteria name to pronounce, but Elizabeth Kingi meningoseptica was the name. Had a very stormy ICU stay for, like you can see, 28 July to like around 2 months of ICU stay, managed by ID specialist and intensivist. So he was treated with prolonged vancomycin Omaha reservoir with intrathecal vancomycin also. This is the exact name of bacteria and the culture report that is we are showing. This is the CSF report and this is the blood culture. Both were showing the same organism. Patient recovered very good, except but he had persistent bilateral sensory neuron hearing loss. But there was no any definite structural lesion to account for that. Any no damage in the any middle ear or nothing was like that. So again in January 17 had a severe UTI with urine culture was showing Morganella that was managed according to the culture susceptibility. Again in April, after 2 months, again he had a persistent fever for a month. All infective workup, including CSF culture, was negative. Again, bone marrow was done to see and whether anything other anything malignancy like was going on that. But again, it was normal. Only hypercellular granuloma was there, still that. So considered to a disease activity, steroid increased up to 10 milligram, and fever subsided after that. So over a period of next 2 years, he had a sequelae of recurrent seizures, orthostatic hypotension, and intermittent balancing difficulties, and that was very significant actually. So till date, last visit, as sir informed me that he was doing well, with this persistent sequelae of the disease, with persistent skin lesions over the leg, but he's managing. So rather than sarcoid, this is the infection that done the all damage and agony to the patient. Thank you. And so the questions I would like to ask that could early steroids plus steroid sparing agent would have changed the outcome? And the second question, etanercept instead of infliximab, would have made any difference? Like less in can we consider less uh, infection producing compared to the infliximab in etanercept? Thank you. So the question open to the panelists and audience to ask any questions.
Romy,
Yes, sir.
very interesting case. I have few questions for you.
Yes, sir.
When was his first chest CT was done?
So that was done first from the first investigation, sir. From the 2006.
Actually, you have not mentioned that CT finding. And when was his eye examination was done by ophthalmologist? What was his ACE and serum calcium levels?
Yes, sir. This is the ACE level was normal. Repeated ACE level was normal, and the calcium was also repeatedly normal. And the CT finding I mentioned in the first slide, CT was normal, sir. No granuloma, some atalectic changes were there only.
Okay.
Yeah.
And basically, that this patient had 7 biopsies: 2 liver biopsy, 1 is spleen biopsy, 1 is skin biopsy, 2 lymph node biopsy.
Yes, sir. Yes, sir.
And 1 bone marrow biopsy.
Yes,
And
2 bone marrow biopsy.
Yeah, and every time his biopsy showed necrotizing granuloma.
Ji, sir.
So, and he received ATT for 9 months initially.
See, many
Actually,
of these, Banwari, Dr. Banwari Sharma, these were all done by a physician under whom the patient was before the patient.
I know, Valki. All this workup was done before coming to you. I know.
Yeah.
Repeatedly, physician suspected only tuberculosis. He never thought of any other possibility.
Correct.
Although necrotizing sarcoid granuloma is a rare entity, but we do see patients
well described. Yes.
Yeah, well described. Regarding Romy's question, we have basically there are case reports and there are small studies that shows that infliximab is definitely better. We have good response at around 80% response rate in sarcoidosis with infliximab. With etanercept, we have only few studies or few case reports, so literature is not very much clear. What is about the role of etanercept in sarcoidosis?
Yes, sir. That's why the decision to start infliximab was taken. But in view of this infection, could it have been avoided? That was the query that came to our mind.
Yeah, basically the infection rate is slightly less with etanercept, and it is seen much more with infliximab. Regarding your first question, yes, definitely, you could have diagnosed this patient correctly. The response rate of steroids in sarcoidosis is very good. and steroids with immunosuppressive drugs, if we diagnose these patients early and treat them adequately, most of the complications can be prevented in majority of the patients.
Can I say
Very,
something?
yeah.
Yeah, Romy, regarding your question about infliximab and etanercept, I don't think etanercept would work in sarcoid, and there are hardly any studies. It's because
Yes.
infliximab affects granuloma formation, all of us know, and sarcoid is a granulomatous disease. The reason you get tuberculosis is because infliximab stops granuloma formation. That is what we want in sarcoid. So there are not very many studies of etanercept. So you would have either adalimumab or infliximab. In fact, most of the cases are only infliximab in refractory cases of sarcoid. So that's regarding your question about etanercept. Regarding the first question, I think it depends on what you would have thought of initially. I don't think one would have thought of anything but tuberculosis in the first presentation, and rightly so in our country. If you have necrotizing granulomas and biopsies, the AFB, as all of us know, can be negative. There are subtle points. I just went through a bit of literature of necrotizing sarcoid, which do help us differentiate between necrotizing sarcoid, which is not very common actually, and something like tuberculosis and infection. Number one is that they say that the necrosis is suppurative in sarcoid, whereas here it is caseous. So that's a bit of difference. The second thing is that you slightly more commonly get vasculitis in sarcoid than in infections. I mean, you don't get that much of vasculitis in sarcoid per se, but between those two, you can get vasculitic lesions in sarcoid biopsies. And characteristically, these vasculitic lesions are away from the granulomas in sarcoid. Whereas in infections, if it has a vasculitis, it is in the area of the necrosis. So that's the second differentiating point. And of course, the third is that generally the inflammatory parameters and systemic symptoms would be more in sarcoid, if at all, than in infection. Of course, you get weight loss and fever and tuberculosis also, but you see more inflammatory parameters slightly more in sarcoid than in tuberculosis. These are three differentiating points apart from AFB and PCR. And you have these tests now which can be done. I'm sure those were not possible then. But regarding the first question, I think it's difficult to put sarcoid as necrotizing sarcoid as the first diagnosis in the very first place. So I think you were right, or the physician was right in treating it. And then subsequently, when you keep getting infections, you either think of immunodeficiency, which was thought of, and I think you went ahead and did a interferon gamma polymorphism also, which was
Yes.
probably less. Yeah, so that's right. Or you start thinking of another alternative diagnosis. And then once you thought of that, yes, you can try immunosuppression, which you tried. So I think it's just that there was slightly more delay, and maybe a bit earlier, something like sarcoid could have been thought of. But otherwise, I think in the first place, even I would have treated this patient as tuberculosis. I don't think I would have been done
I
it.
think this patient taught me a lot, as patients do. And the most important thing was most of the things were already done before the patient came to me. So that made it easier for me to think of other things and think of necrotizing sarcoid, which I'd seen 2 or 3 patients like this before. So that's why I thought of. But the other giveaway was the psoriasiform skin lesions, which I had not seen in TV. And we've had a few patients with this typical psoriasiform plaques on the skin of sarcoid, and it's a giveaway. And a proper biopsy of that many times give a diagnosis. But the funny thing was, even the skin biopsy showed necrotizing lesions, which is a little odd for sarcoid, but probably can be seen as well. And so that was a giveaway for me. And after much discussion with the patient, we did give TNF, it did help. But unfortunately, we did land up with an infection, which we managed. He still comes for follow-up. He's much better now. He's off his walking stick. He's having his, he's wearing his ear apparatus, and he's going ahead and is back to work, which is nice to see after about 2-3 years of difficulty which he went.
Balki bhai, one more interesting thing about sarcoidosis and sarcoid granulomas. Recently, I reviewed the literature and I found that sarcoid can occur with combination with another autoimmune disease. Sarcoid can occur with infection. There is combination of sarcoid and infection even without immunosuppressive medication. That is also seen. Sarcoid can occur with other granulomatous disease like Crohn's disease. Sometimes all these have been reported. Very interesting case.
I think with that, we come to the end of the first case. So if we can want to proceed with the second one.
Does anybody have any questions? Or
Yeah, there is one question in the chat box from Prashant Chotalia. Why splenectomy was done?
Because
There was a suspicion of malignancy. So initially, that was done initially. And in view of pancytopenia was there.
hypersplenism and malignancy was thought of by the physician. So that's why
Yeah.
this.
Right. And there are a couple of questions for Kaushik, though they come in late. Kaushik, any role of fecal transplantation in rheumatoid arthritis is the first one.
The microbiome is getting more and more important in all kinds of conditions. I think there was an IRA webinar a couple of weeks ago where the microbiome was dealt with in the seronegative spondyloarthropathy. So I'm not conscious of any trials that have been done, but one can safely say that as we move on, the microbiome and the gut flora will definitely be very important and will probably be far more important than we have given it credit for so far.
The second question was, who discovered intra-articular injections? From Professor Ved Chaturvedi.
That's a good question. I honestly cannot remember the name, but what happened in the early 50s is there was a lag period between the oral form of the steroids, and as you know, that it went through different formulations. So it's hydrocortisone, prednisolone. They all didn't come at the same time, but it was probably in the late 1950s, if I'm not mistaken, around 1957-58, that the first injectable forms of steroids were available and in fact were used in local injections to the joints. The important thing to remember, though, is when the steroids were being used initially, there was a very high doses were given, and gradually people began to realize that they were very high doses, because what happened was the problems related to chronic steroid use began to come out of the woodwork, a few years down the line, with fractured bones, infections, and all the rest of it. So, the initial honeymoon period when steroids were thought to be the definitive treatment for inflammatory conditions like rheumatoid didn't last very long, and then you, as you well know, rheumatologists certainly, they go through this cyclical phase of falling in love with steroids, falling out again. But what I think is also important is, although I can't answer Ved's question directly, it is important to know that there are so many different things going on in the world of steroids, and in an effort to make it less potentially toxic but as effective, there are whole new formulations and selective manipulations of the steroid molecule.
There's something on the net which has been found, that there was a letter to the editor in 1954, and they said that intra-articular injections of hydrocortisone have now been given in 17,000 instances to more than 1,300 patients at the hospital of the University of Pennsylvania. And they said that what we need to do is improve the technique and use the correct methodology to inject so as not to introduce infection. So maybe slightly earlier than 57, 58.
Maybe earlier. You're absolutely right, Madam President. I stand corrected. But I think injections still are very much part of what we do to our patients. And in terms of in overall use of steroids, oral, intramuscular, intravenous, and intraarticular. I think intraarticular probably is the best way of using the least volume or least cumulative dose of steroids to get the most benefit, especially if it's a few joints. In fact, I recall remind the listeners about the Ticora trial. The Ticora trial actually was a combination of conventional disease-modifying drugs and intensive intraarticular injections. People would come every month, and anything that hurt, they'd be injected. They'd be like a pincushion afterwards. So it's something that, if money does not extend to biologics, it's something we can still do.
I think we can move on to the next case. And Dr. Bankimbai, can you introduce this?
Okay. Yeah, thank you very much, all panelists, Kaushik, Namesha, for that brilliant case, Romisha. We move on to the second case, who is going to be presented by Monish Patel. Monish is another upcoming and in-making rheumatologist. He's a second-year fellow and trained at the KLE University, Belgaum, Karnataka, for his MD medicine, and now uh, is doing his fellowship in rheumatology at NHL Medical College and the VS Sardar Patel Hospital under Dr. Sapan Pandya. Monish, your case, please.
Thank you, sir. I'll share my screen now.
We've not got the slides, Monish.
Just as
Yeah. Okay, take your time.
I think
Can the technical team help him, please?
Technical can.
Yeah, sure. Is it visible?
Yeah. Well,
Just a second.
Not your slides.
Okay, I'm sharing the screen.
Yeah.
Actually.
Yeah.
Yeah, that's.
We can see that.
That's fine.
Yeah. Just a second.
Yes, you can start, Monish. We can see.
Yeah. Actually, my screen is.
Is it visible now?
Yes, it is.
Yeah. Is it visible? Okay.
Yes.
Okay, good evening, everyone. Thank you for the introduction, Bumpkin sir. I'll try to extend my gratitude to the RAG group and the Cadila group, especially to Namisha ma'am and Sapan sir as well. So this is the case. I'll first describe the case summary and a short review of literature that I've done for this case. So it's a case of 50 to 54-year-old male patient. He was a diagnosed case of psoriasis vulgaris since 15 years and managed by topical agents at that time. He was referred for the first time to a rheumatologist for right ankle swelling. So in 2015, a rheumatologist saw him for the first time on the background of psoriasis. He at that time had a monoarticular involvement only of the right ankle that was present at that time for 3 years in a typical relapsing and remitting pattern. Negatives that were at that time, he did not have any axial involvement, IBD or family history or a history of uveitis. On the routine workup, it was found he had elevated inflammatory markers. So methotrexate was started with NSAIDs at that time. That gave him partial relief for about 1 year. But by the end of 1 year, he developed methotrexate intolerance. So he was shifted to sulfasalazine and leflunomide combination, which was also only giving him partial improvement for about another 1 year. So by the end of 2 years, when he came back in 2017, the pain and the swelling were still persistent. So at that time, intra-articular steroid injections were planned, which gave him nearly 6 to 8 months of pain relief, but the swelling was still there. By that time, psoriasis on the background had a typical relapsing and remitting pattern, but more than 5% of the body surface area was always covered, always involved. After this, he was kind of lost to the follow-up. In 2019, he came for his third consultation. At that time, he had stopped all DMARDs for more than 6 months. Right ankle swelling had increased at that time with reduced on examination tibio-talar and the talo-navicular joint movements. X-ray was done which was showing joint space reduction with secondary osteoarthritis in those joints. And psoriasis had also flared up. It was extensive at that time. So he was restarted, which he had stopped at that time, sulfasalazine and leftonomide. And for future, he was discussed with the for probability of going on biologics or apremilast. For the next three months, in 2020 he came back. Still the pain was still there. So again, USG guided intraarticular steroids were given in the right ankle, which gave him a good relief during the lockdown period for 2 months. In May, again he flared up for psoriasis and arthritis. Was advised to go for biologics, TNF inhibitors next time. So for screening, he was asked to go for Montauk's test and IGRA, but due to the pandemic situation, probably they did not get it done, and he directly received the first dose of adalimumab 40 mg. Now after receiving the first dose, within just 1 week he developed increased pain worsening of the ankle and swelling together with sinus formation and pus discharge as well. So the local surgeon was brought in. He did the local debridement and the pus showed pseudomonas. So he was treated with appropriate antibiotics for 15 days, but there was no improvement at all. X-ray was showing features of osteomyelitis, so an MRI was done. I'll show you the image first. So this was the MRI. This is the T1 weighted image. We can see extensive erosions as well as bone marrow edema, which is seen as patchy hypointense enhancements in the tibio-talar joint here, with soft tissue involvement as well around the joints. This is the post-contrast coronal plane image. It is showing patchy bone marrow edema here in the bone, and surrounding that, the tendons which are going parallel to the bones, which are showing enhancement of the contrast, picking up the inflammation. So if I go back, debridement was done at that time. A drain was placed and the TB culture was done again, which came positive. So he was started on ATT. Within 2 months itself, the discharge stopped and the patient was walking comfortably pretty much for the first time. So further plan so far has been planned to complete the ATT for 9 to 12 months and a topical treatment to be continued for active psoriasis with only NSAID support. So this is actually a summary of our experience with infections with the use of TNF inhibitors here in the RAG group. So with adalimumab, we have seen one pulmonary TB case, but with infliximab, there were 6 pulmonary TB case and 1 TB meningitis case. And in etanercept also relatively less cases are there with only 1 pulmonary TB case. So I did a small review of literature here. This was published in 2019 from AIMS. So musculoskeletal tuberculosis amongst the patient with TNF inhibitors are relatively more as compared to the general cohort. And out of the extrapulmonary tuberculosis cases, nearly 10 to 30% are musculoskeletal TB. So that is much more significantly proportionate as compared to the other cohort. Now, amongst those, pot spine is most common, presenting as nearly 50 to 60% of cases, but they can also present as osteomyelitis, septic arthritis, soft tissue abscess around the joints, and or even without the joint involvement, and rarely reactive arthritis, which we call as Ponson's arthritis. Tubercular arthritis as such does not have any pathognomic features which can differentiate it from other arthritis, destructive arthritis, but it can involve any joint of the body, so it's always a clinical dilemma. And adding salt to that wound is a fever and constitutional features of tubercular infection are mostly absent in those patients. So this is a typical example of involvement of large joint in the upper images. First, this is the hip joint involvement on the upper left image. This is the T1 weighted image. We can see here joint space is reduced as compared to here. And typically there is hypointense bone marrow edema that is seen here with erosions. So we can confirm it here with increased synovial effusion with erosions and the hyperintense activity on the T2 weighted image. This is for the small joint involvement. So unlike in the SPA groups, small joint is said to be quite commonly involved when we talk about tubercular arthritis. So this is T1 weighted image. Here it shows a soft tissue involvement around the carpal bones as well as increased synovial fluid collection here. This is the stir image. It shows hyper intense activity in the as a bone marrow edema in the base of the MCP as well as the carpal bones. Together with that, we can see the involvement of in the form of tenosynovitis in the extensor digitorum tendons. This is the post contrast image where we can see the synovial pockets picking up the contrast material.
Have we lost contact?
Yeah, I think so.
We have lost his contact.
Can the technical team
I
help?
think he's speaking, but
And this is the summary actually of the two.
Monish, I think we lost your voice for a while. So if you go
back to
back
one
to
slide.
that couple of slides,
Here, ma'am.
we lost you for your voice for a couple of slides. So if you go back to that picture, is it TB or
Yeah.
psoriatic arthritis? If you
Yes,
start
this one,
from
this
here,
one, yes, yes.
yeah,
Here, sir. Here, ma'am.
yeah. Please start from here.
Okay. So this was a study done from AIMS in 2019. So it was basically an epidemiological study of musculoskeletal tuberculosis. So the prevalence of extrapulmonary tuberculosis infections are increased in patients with TNF inhibitors as compared to the normal cohort of patients. And we are seeing about 10 to 30% of extrapulmonary tuberculosis patients presenting as musculoskeletal tuberculosis. And amongst those, pot spine is most common, presenting in 50 to 60% of patients, but they can also present as osteomyelitis, septic arthritis, soft tissue abscesses, and rarely reactive arthritis. Now, when we talk about tubercular arthritis, it does not have any particular pathognomic features as such, but it's a destructive arthritis and can involve any joint of the body, practically large or small. Adding to this difficulty of diagnosis, fever and constitutional features, which are very commonly seen with tuberculosis infection, that are absent in these patients. So we tend to miss these patients as such. These images are showing the large joint and the small joint involvement. The hip joint involvement with tubercular arthritis here, if we can see in the left corner, that there is on T1 weighted image, there is hypointense uh, hypointense part is observed here in the hip joint, which is indicative of bone marrow edema. Reduced joint space together with erosions are seen here, which are confirmed on the T2 weightage image with hyperintensity of the bone marrow edema. Erosions are clearly seen here, and even the synovial fluid collection is more here. Similarly, for the small joints, literature wise, we know spondyloarthritis group mostly involves the large joints, but tubercular arthritis involves small joints almost equally or sometimes even more preferably. So this is the T1 image of a patient having tubercular arthritis. We can see soft tissue involvement here as well as increased synovial fluid collection here near the carpal bones. And this is the star image showing the hyper intense bone marrow edema in the carpal bones as well as at the base of the MCP. Together with that, tenosynovitis can be clearly appreciated here in the extensor tendons. This is the post contrast image where synovial pockets have collected the contrast material and they are quite enhanced to show the synovial inflammation. So now there is even dactylitis is quite common presentation for musculoskeletal tuberculosis. So we can imagine our clinical dilemma if a patient of psoriatic arthritis is not getting treated or is refractory on conventional DMARD, then we shift him on TNF inhibitors and they develop dactylitis. And we should always consider tubercular arthritis also as one of the important differentials before labeling the patient as refractory. And this is a summary of the two studies that have been done for the assessment of risk of tuberculosis in Indian patients, particularly on being treated for by TNF inhibitors as such. This was done in 2014. The objective was to see for absolute risk increase of developing tuberculosis with TNF inhibitor therapy specifically for India. So it was the statistics were specially designed for Indian cohort. So ARI risk, it was seen, this is for per 1 lakh patients. So with adalimumab, it is seen to be nearly 5,000, while in etanercept, as we had discussed earlier, it is less prone to develop tuberculosis as compared to infliximab also, which is quite high in comparison. NNH means numbers needed to cause harm. So these numbers basically indicate the minimum number of patients treated with TNF inhibitors for the first patient to develop tubercular infection among that group. So higher the number, safer is the drug. So we can see adalimumab and infliximab are relatively having less numbers and more chances of developing tubercular infection as compared to etanercept, nearly 10 to 12 times less. So the conclusion of this study was etanercept comparatively had lesser incidence of tuberculosis in Asian population. This other study was done, it was actually specifically done for ulcerative colitis patient on infliximab in India. A total patients 79, 3 developed disseminated tuberculosis and 4 had pulmonary tuberculosis. But the feature was the outcome of all the patients was very good actually. All of them were successfully treated with ATTs within 6 to 13 months. So the conclusion of this study basically was even we know that there is higher incidence of TB in our country, fatality due to TB after infliximab therapy is very less, and they can be easily treated with timely implementation of ATT. Thank you.
Thank you, Monish.
Right.
I request the panelists to discuss the case, please.
Yeah, a few points that I'd like to make. I was involved with a study recently with our orthopedic colleagues here in Mumbai. We have seen 140 patients of osteoarticular TB, which are microbiologically confirmed. And this has been published in their orthopedic journal. And the few important points was, startling was about 20 to 25% were multi-drug resistant. So that's something which we have to realize that not all of them might be susceptible drugs. The second important point was, it's very imperative, especially in cases like this, when there is a sinus, to do a proper debridement. Just medications alone will not lead to the healing, and you will have to do a proper debridement. And when done well, that itself hastens the recovery of these patients quite a bit. As far as differentiation between monoarticular psoriatic and probable TB is concerned, I would probably say that these, apart from a tissue diagnosis, radiology can give a very good clue. If there is a very early destruction of the joint, the very early destruction, I would mean even 2-3 months down the line after an inflammatory arthritis, we don't see so much destruction. Radiology X-rays take a little longer to change. But if somebody has a destruction of the joint within a few months, then an infection, especially a chronic infection like TB, becomes more important. A larger soft tissue, especially going beyond the confines of the synovium around the joint on radiology, again makes infection more likely than inflammatory. But these are just pointers that would help you, but eventually you will need a proper tissue diagnosis.
Monish, very good case, interesting case. I have few queries. He had septic arthritis, right ankle joint. he received intra-articular injection also. He was given adalimumab 1 week prior to that. How commonly we see tubercular arthritis after 1 week of anti-TNF drugs?
Not common, sir. It requires at least 1 to 2 months. Usually 1 week, like following 1 week should not be attributed to TNF inhibition therapy. It must be present before that. Infection should be present before that.
And basically, he had bacterial plus tubercular combination of both. He had bacterial infection also.
Yes, sir.
And inflammatory arthritis patient, they are prone for the septic arthritis. They are prone for the septic arthritis. So, is it because of the disease or because of the drug, intraarticular steroid, or because of anti-TNF, or combination of all three?
Yes, sir. Yes, sir.
That was my question. How early one develops the infection after giving adalimumab or TNF alpha?
Yes. So the. Oh.
Go on, Monish, answer
Yes,
that.
so the review of literature that I said was actually not specifically addressing this issue, but retrospectively, whatever information I found was at least 1 to 2 months was the period before they developed due to the TNF inhibition.
When is tuberculosis most likely an anti-TNF therapy?
But pulmonary tuberculosis and even fever, worsening of the fever, and sometimes respiratory symptoms we can develop in few weeks.
It's usually in the first 6 months of anti-TNF therapy that's why the most of the prophylactic regimes are the first 6 months. And that's why there was this theory that the loading dose, the TNF levels actually go down in the first 1 or 2 months, 3 months, or up to 6 months. That's when the greatest chances of tuberculosis are. After that, the chances are lesser, especially with infliximab, but also with adalimumab. Right? So,
What is interesting in this patient is it's known, like in subacute bacterial endocarditis, a damaged wall is many times a place where the infective endocarditis occurs. We know that pyogenic osteomyelitis and arthritis occurs when there is a damaged joint, but TB occurring in a damaged joint is something that I've seen for the first time, and it's very interesting.
yeah, so I was involved in this case actually, and it was Tara who actually picked up the infection because the patient kept shifting. And one lesson we learned and we discussed in our clinic is that maybe we should do MRI slightly earlier in patients who keep on having swelling despite treatment, and we should not stick to just clinical stuff sometimes. So this patient, for 3 years, obviously he had psoriatic arthritis, and the first time he had sort of denied to an intra-articular injection. Many times they denied, so we gave DMARDs and all that, and then finally agreed for intra-articular. We gave ultrasound guided. He improved, but then meanwhile we had counseled. The skin people also wanted something, and then he got this infection. So, but the MRI could have been done slightly earlier, when there was this, and so we thought that every case has to teach you something, So we decided that maybe we should do more MRIs, and as you said, those give us clues, of soft tissue infections and.
And MRIs around the ankle will be very useful even in just psoriatics, because it will tell you the pathology, whether there's a synovitis, whether there's an enthesitis, or whether there's a non-infectious bone edema which is causing the problem. And then your therapy could be kept specific for what you see there.
Sapan, if you see the registry data from our orthopedic colleagues, in these patients, after doing hip or knee transplant on biologics, there is no significant increased risk of infections or tuberculosis in the joint in majority of the registries.
Most of them recommend continuing the biologics.
Yeah.
Going to be just one half-life installment. Kaushik has anything to say? Is he around?
Yes, I am. I think we need to be very mindful of infection, and with the more powerful drugs, the standard inflammatory response is not seen. We've seen infections not just with tuberculosis and other bacteria with tocilizumab, where you won't get a rise in ESR or even the clinical features. So I think in someone who is on powerful medication, particularly biologics, you should have a very low threshold of suspecting sepsis for persistent joint swelling, and be really careful in injecting them as well. Sometimes, that's what we've learned.
Yeah, so that was the
Kaushik,
whole purpose. Are there any questions we can take? I
yeah.
wanted one final comment. Just give me one chance before you.
Yeah, Kaushik and Sapan, there is a question which both of you need to answer. How frequently should one do liver function test and kidney function test for methotrexate treatment? So the Indian scenario and the UK scenario.
Well, the Indian scenario, there's no Indian and UK scenario actually, so these are recommendations. But I think what we normally do is every month for the first 3 months, and then every 3 months for 6 months, and then 6 monthly. That's a recommended regime as I see it.
Is it any different in
There are
the
some recommendations that maybe you can do them lesser in younger patients and those kind of things. But what we practice is at least monthly for the first 3 months, and then quarterly for 6 months, and then every 6 months.
Kaushik, is it any different?
It isn't, except sometimes we need to personalize the monitoring, because in the UK there's a lot of very elderly patients with a lot of other drugs. So not least, they're taking sort of hypertension drugs, this, that, and the other. So the two broad streams, if you like, or the two broad areas we monitor are the renal function and the liver function. So in some, the renal function becomes very important. So I mean, as Sapan said, the BSR guidelines are pretty straightforward, but people do exercise a certain amount of subjective tinkering with the guidelines, and I think that's not unreasonable. In COVID, it's been a real problem for getting patients to have blood tests, so we've had to come up with really innovative ideas. Sort of tents have popped up in car parks where people can go in because they are desperately unkeen to come to hospital, and even very a lot of the GP surgeries are not offering these blood tests. So we've had to adapt a lot and it hasn't gone away yet. But I think, broadly speaking, the principles are you monitor more closely, and I suspect in India it's determined by the patient's ability to have the test. It comes at a cost. We're not constrained in that respect. But when we started, the first test would be in 2 weeks, then in a month, and then 3 months and 6 months. I have to confess that I worry slightly about patients going every 6 months, particularly if they're on high doses. But that's just me.
There's a question, one more question for Banwari and Balki. Your thoughts on COVID-19 and use of immunosuppressants, including biologics. Would you use them, stop them, or be more careful?
I've been fortunate enough to be doing COVID duties for the past 4 months. I've been doing once a week, and every fourth week, the weekends, see about 15, 20 patients every time. We've had quite a few of our patients getting affected with COVID. What I normally do is I stop the DMARDs for at least a couple of weeks until they settle down, and then restart them once they are better off. I've not had patients of biologics getting COVID as yet, so maybe Banwari can talk about that.
Yeah, basically, if we see the available literature, now we have enough literature and we have enough experience that the primary aim is to maintain low disease activity or remission. Rheumatic disease patients should be in remission or low disease activity. And majority of the rheumatologists, they recommend to continue all DMRs and biologics to maintain low disease activity or remission. And only exception is if patient is on a high dose of steroids. That is the only worry. Otherwise, I think we should continue DMRs and biologics.
Would you start them during the pandemic?
It depends. If patient is definitely, if patient has aggressive disease like patient of GPA, present with pulmonary renal syndrome, alveolar hemorrhage and high serum creatinine, rapidly progressive disease, yes, I would go for the rituximab.
The other thing is many of them who have respiratory involvement along with hypoxia are already on steroids for the COVID.
Yes.
And many times you find that itself stems at least the inflammatory arthritis down for a couple of weeks. They're usually there for about 7 to 10 days. And sometimes if they're hypoxic and have changes, significant changes, COVID changes in the lungs, they're given for much longer periods of time. So that itself takes care of this for a while. So just to reduce the interactions, and many of these people are elderly. The ones who are getting admitted to the hospital are not young. They're usually in their 60s with comorbidities. So just because of that, I've been a little bit more careful, and I've asked them not to take all this. And because we can always review them after they come back, and that's what I've been.
Right.
But Balki, I am talking about the OPD patient, not the
OPD.
IPD.
Okay. Just a final question to Romy and the panelists. Was there any clue of sarcoid at the beginning for case 1? And in absence of high ACE levels, how can we suspect sarcoidosis? And I think this would be the final 2 questions.
Namisha, ACE level is elevated only in 60% of sarcoidosis patient, not in 100% of the patient. And even if it is elevated, there are so many other conditions where we get high ACE levels. So ACE level is not diagnostic. It is only suggestive with clinical picture. That's all.
Yeah. Thank you. Romy, was there any clue that this was there was sarcoidosis at the beginning when the patient was presented to you? Did you think of sarcoid as a diagnosis?
Actually, he presented to us after 8 years of extensive
Yes, exactly.
investigation. So, not getting better on the EKTs repeat, that was the only clue.
Yeah. Okay.
Last question that I just want to ask to panelists for the second case. In psoriatic arthritis, monoarticular joint, should we use TNF alpha blockers?
No. Ideally, no.
Ideally, no.
The rest would be intraarticular steroid, and then in this patient, you
Yes.
see, tried everything. He also had a lot of psoriasis, so that
Yeah,
was
yeah,
another reason
exactly.
why.
Yeah.
But I think now data is more in favor of anti-IL-17 as regards
Yes,
psoriasis.
secukinab.
And that's also safer in terms of tuberculosis. I had 3 comments to make, Namisha, before we wind
Yeah,
up.
yeah,
One is
sure.
regarding the biologics and COVID. So there is now enough data to show that patients on TNF actually are doing better, and they are more OPD than IPD. So because we know that cytokine storm is actually because of immune response. So patients on TNF have generally done better in the US. Only in this month, Southern Rheumatology, there is data from Lombardy, Italy, about 990 odd patients, and only about 0.3 got COVID. And those on biologics were maximum TNFs were actually doing much better. Even those on Barry and Tofar did much better than those, So I think it's not a problem in patients with ongoing biologics. The only problem we have had is one patient of mine, I think one patient, Pooja, also had, who had Wegener's, as Banwari was said, and COVID. In that particular situation, it becomes very difficult to make out whether the flare is because of GPA or whether it's because of COVID. And both of us lost one patient each to rituximab. I mean, the patient was already on rituximab, was given, landed up with COVID. So rituximab is one drug which probably we have to be slightly careful in terms of, because it doesn't seem to benefit COVID, unlike TNF and the other biologics. That was the first thing. Second thing was that the purpose of this symposium was to, as Kaushik Danas discussed before, to be careful about infections. That was a take-home message for, since we are going to use biologics and small molecules more and more, we have to be very careful about infections. That's why we took up 2 cases which had infections. That was the whole idea. The third thing regarding Kaushik Das talk, I had a comment, but I didn't. I thought we wouldn't have time then. So I wanted to say that there was this very interesting perspective sent by Balki Boss to me from the BMJ, if he remembers. It is one of the most well-written articles I've seen, in which the author wrote that if you look at the last 50 years and the 50 years beyond before that, in the first part of 50 years, compared to the investments which were negligible, the returns of science, even in rheumatology, were much more than what we got in the last 50 years. The amount of investments we've done into research and the amount of gain we've got from that. Your comment on that, Kaushikda?
I think to some extent, rheumatology has evolved in the consciousness of the medical fraternity. We all know that there is a pecking order in medicine, right? So cardiology used to hold sway. Now, of course, with preventive drugs and all, they don't strut around as much as they used to. And I think heart surgeons are dwindling in numbers. But I think if you look at the history of how specialties have evolved, you can see that rheumatology actually was always the bridesmaid, never the bride. We came into the forefront once anti-TNF came on board, and to some extent that is being driven by the industry. So I think the sort of the overall importance of rheumatology has only become come to the surface since we have effective drugs. Before that, rheumatology associations were all, physiotherapy, physical therapy, all of that. So as a specialty, we have come of age. And with that, investment has flown in. And it has to be said that if you look at the orphan diseases, the investment still is from government agencies. We still haven't got anything really going for Sjogren's or scleroderma. It's where industry has stepped in that the investment is flowing, and that's the reality.
One good news is that the DM and DNB aspirants, I hear that rheumatology is top notch these days. That's some good news.
Absolutely.
Amisha, I think we will go to
Yeah, I think so. Banki Bhai, do you want to give your vote of thanks?
Yeah, just close up. Yeah,
Yeah.
you can go ahead.
Yeah. Thank you very much to all those who attended. And we don't know the numbers, but I hope it's a large one. Thank you to the panelists for being here and accepting the invitation. Thank you, Kaushik, for your talk, which was very interesting. And thank you especially to the young aspirants, Romi and Monish, for putting up two very good cases and which led to a lot of good discussion. I wish we had more time and we could have gone on. Thank you very much for Cadila for joining hands with Rheumatology Association Gujarat for hosting these two webinars. And this is the first one. The next one is on 8th of November on osteoporosis as the topic. And I'm sure it'll be as interesting as this one. Thank you very much, everyone, for being here.
Thank you.
Thank you very much, Amisha Madam and the RAG, Dr. Sapan, and all the speakers for a fantastic session. And as we close this session, I would like to remind the audience about the next weekend programs, which are on next Saturday and Sunday, and also request everyone to visit the exhibition stalls. Thank you very much. Have a great evening.
Thank you.